What's up, guys? It's Dr. Tim Jackson with another episode of the Boss Body Podcast. You know, we've talked a lot about breathing on the show, maxillary width, jaw angle, dentition, height, etc. So I brought in an airway specialist, an ENT, who treats root causes, doesn't just do surgery for the sake of doing surgery. Dr. Kevin Smith.
While I make every effort to broadcast correct information, I'm also still learning. I will double check all my facts, but realize that healthcare is a constantly changing science and art. One doctor or healthcare provider may have a different way of doing things from another. I welcome any comments, suggestions, or correction of errors. I take no money from supplement or device companies. By listening to this podcast, or reading this blog, you agree not to use this podcast or blog as medical advice or to treat any medical condition in either yourself or others, including but not limited to patients that you are treating. Consult your healthcare provider for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast or the website. Under no circumstances shall any guests or contributors to the podcast or blog or any employees, associates, or affiliates of the Boss Body Podcast be responsible for damages arising from use of the podcast or the blog. This blog or podcast should not be used in any legal capacity whatsoever, including but not limited to establishing the standard of care in a legal sense or as a basis for expert witness testimony. No guarantee is given regarding the accuracy of any statements or opinions made on the podcast or the blog.
Welcome to the show, Dr. Smith.
Thank you for having me.
Absolutely. So tell us a little bit about your practice and how it's kind of evolved since you left residency.
Thank you. Thank you. Yes, I've been practicing 30 years now. It's amazing how fast the time passes, but it's been a great 30 years, I tell you. I enjoy ENT because I enjoyed the head and neck anatomy in medical school. I did a fellowship in facial plastic surgery, so I'm double board certified. I think my plastic surgery, because you have to be very detailed and analytical, actually helps me on my medical ENT side with sinus and nasal anatomy and surgeries to help increase the patency of the nasal airway and the oral airway. And it also helped me to be very analytical in finding out that nasal abnormalities, specific nasal abnormalities, can lead to these chronic headaches and chronic migraines that people suffer from. And it's important to state that it's not a sinus migraine. I've actually eliminated all type of migraines, family members with the migraines, hormonal, hereditary, complex migraines that resemble a stroke, and the like. The list goes on and on. But the practice has evolved. Initially I was doing sinus surgery, and of course, a lot of those patients can have headaches, and they would tell me that their headaches went away after my procedure, and I was like, okay, good, that's wonderful. And then I found myself concentrating more and more about these headaches that would go away. And when I looked at my data, almost 90% of the people that came in had a history of migraine. So I was like perplexed because in medical school and residency, you're taught that migraines originate in the brain. So I'm thinking, okay, these must be migraine imposters. They act like a migraine. They're very serious headaches. I'm getting rid of them with a nasal surgery, so they can't be migraines. So they're getting misdiagnosed, and these are migraine imposters. So I would market migraine-like headaches. If you suffer from migraine-type headaches, I had to get the word migraine in because migraine sufferers, if you just mention chronic headache, they consider themselves outside of that group. They're a special group. These are severe, debilitating headaches, which they are. So I had to tie in that word migraine to get them to come in because I was curious. I've always been just a curious, like a kid, I'm always like, let me see, what these people have. The last 10 years or so, though, I was on a show with a lady who had migraines, and she was 4 years migraine free. And I mentioned on the show that everyone across the country could have access to my expertise by sending me a copy of their CT scan disc of their sinuses. And so I get these random scans from all over the country. Lo and behold, nearly 100% have the abnormalities that I'd been fixing all those other years. And I sat back and I just took a deep breath and I said, wow, all this time I thought I was curing migraines. This is the root cause of migraine. This is crazy. This is amazing. And ever since then, I've just been on this path where I market that I eliminate migraine headaches, chronic migraine headaches, by using a nasal procedure. That procedure, of course, over the years has been refined and refined and refined. And now I achieve a little over 90% success in eliminating migraines in people. I'm still striving for that 100% because I know the root cause is in the nose. You know, I know it's there. It's like, what am I missing? What else am I not getting with that 10%? So yeah, so my practice has evolved. I still do some facial plastic surgery. I do facelifts, eyelids, and nose jobs. Those are the three things that I've kind of distilled my practice down. And I've really embarked on this chronic migraine, chronic headache, nasal airway obstruction path because there are 40 million people in the United States with migraines. There are 1 billion people in the world that can benefit from what I do. And it's very easy for those that are not in Houston. You just get a sinus scan, or even I tell people you can even send me your latest brain scan because the migraine patient's going to get brain scans more often because they go see neurologists. But I have to tell you that 95% of brain scans done on migraine patients are normal. So the root cause isn't there. It's not there if it's normal. The opposite is true for the sinus scan. But they can
Said
send me their scan.
95% are normal.
95% of all brain scans done on migraine patients are
Wow.
normal scans. They don't show a tumor. They don't show an aneurysm. They don't show an infection. They're normal. And I have some patients that had 10, 12 brain scans during a 30-year period that are normal.
Right.
It's not
Yeah.
there.
That's crazy. And, going back to something you said, about what you learned in medical school about it being migraines being a brain issue, they tell you, I think in almost all healthcare doctorate programs, 50% of what we teach you is going to be wrong. We just don't know which 50% it
Yeah,
is.
you're right, right. And that's the good thing about medicine. And that's the good thing about practicing medicine, which is what I've done. You have to do certain things and then be astute enough to be analytical enough and observant enough to see what the result of what you do is. And after seeing it over and over, I was like, man, this is incredible. This patient had migraines for 40 years, never worked, was devastated, depressed, disabled, uh, didn't interact with family, couldn't go to important events, couldn't travel, go on vacations, kept a bucket with them at work because they threw up every day, all day. And then I eliminate that with a 1-hour procedure. It's covered by insurance, 90% success rate. It's just amazing. It just feeds me. It really
Absolutely.
feeds me because I'm giving people their lives back.
And so, in functional medicine, when we hear migraines, we think progesterone deficiency, magnesium deficiency,
Mhm.
but, also a lot of times people forget to look at the structural
Yep.
component,
Yep.
and, structure determines function and vice versa. But
Right.
uh, what else? So when someone comes to you, is it mostly migraine patients, or some people just say, I can't breathe well, Dr. Smith, what can you do?
Oh, wow. There's a host of things that let's just start with nasal airway obstruction so everyone understands what nasal airway obstruction can do. And when you fix it, you can help eliminate these things. Nasal airway obstruction caused by a deviated septum or large turbinates. These are the air filters in the nose. They swell and shrink in response to cold, flu, allergies. If you eat a salty meal, water retention during your menstrual cycle, you get congested. You can. This can lead to a host of symptoms: runny nose, postnasal drainage, chronic coughing, pertaining to the ear. You can get intermittent ringing in the ears, muffled sound, water sensation, dizziness, which can be labeled as Meniere's disease. But my thing is, before we give them that complex diagnosis, check the nose, fix the nose, optimize the nose. A lot of times I've seen people with these things go away. It can also cause the chronic headaches we mentioned and the chronic migraines, chronic sinusitis, recurrent sinusitis, inflammation, infection in the sinuses, achy facial pain, cheeks, forehead, top of the head, ear pain can be caused by it. eustachian tube dysfunction. Um, I see a lot of people with all of those entities. Oh, snoring and sleep apnea. So the nose is tied into all those things. And let's take sleep apnea, for instance. You know, you have devices you can get, you have things you can try, you have the CPAP mask, you have the BiPAP mask, you have the Inspire implant, uh, oral devices, which are all very good. They help, don't get me wrong. But before you give someone a device, it is my thought that let's look at the root cause. Let's examine the nose in detail, examine the throat in detail. If those structures are imbalanced or too big or deviated septum, for instance, let's fix those things first and see if those symptoms get better. And a lot of times I tell you, more often than not, 90% of the people that I treat, the symptoms get better. And they're like, wow, Dr. Smith, how did you know to do that? You know, and you just, after 30 years of practicing something and being pretty astute and curious, you just know the body is made in a certain logical way that's very explainable, understandable, and you just have to understand how those things are all linked in order to achieve the results you need, which is to get a patient better.
Right. Absolutely. And one thing I've seen, I'm glad people are more aware of, the importance of nasal breathing, but
Yes.
mouth taping at night. So if you
Mhm.
don't have nasal patency and the only way you're getting oxygen is opening your mouth, if you just go to taping your mouth, that could be really bad.
It
Um,
can be. I've seen that, and I'm like, you don't want to do that in somebody if you don't know the status of their nose condition.
right.
Now,
Yeah.
once you might have to retrain yourself once you get your nose fixed if you have a problem with that. But because you're used to mouth breathing. However, I wouldn't recommend taping your mouth unless you know that, okay, my nasal structure is normal. I'm just a mouth breather for whatever reason. And I want to retrain myself to breathe through my nose. Right. That's dangerous.
Absolutely. Yeah, I've said that and I've gotten nasty messages because of it, because it's not
Really?
popular.
Oh,
My opinion's not popular because,
yeah.
it's kind of in vogue. But, there was a video that went viral of a guy, he had like the clear tape in his mouth, and he had like a camera filming him while he slept. And he's like, starting to pull on it, while he's
Hmm.
sleeping because he
Hmm.
can't get oxygen through his nose.
Right, right.
And, if you have a deviated septum, large turbinates,
Polyps.
polyps, yeah, all those things. And so there's a procedure, and you'll probably know the name of it. I've read about it. They put something up your nose to dilate the nasal passages while you sleep. I mean,
Mhm.
think it's relative like little wires. Have you heard of that?
I have not heard of that. Um, I can tell you that you can dilate the nostrils. If it goes any farther than that, it probably could push on those turbinates because they're erectile tissue and maybe kind of push that out. Probably help as long as you don't scratch them or cause the nasal bleeding because you've lacerated the turbinate or something like that. But if you run that up against a deviated septum, I oftentimes explain the headache relationship to the original COVID test that we get, where they stuck them way in your nose. Those things hurt. They
Yeah.
hurt until it was removed. And so, what a lot of people have with these chronic headaches and migraines are essentially a permanent COVID swab in their nose, making contact with sensitive tissues and causing chronic headaches. That's the simplest, understandable way that I use now to explain to patients how this anatomy in the nose can lead to these chronic headaches and migraines.
Yeah, absolutely. And in terms of like traditional ENT, like you're obviously not a traditional ENT. Um, but how have you been ostracized because you view things a little bit differently?
Well, I can think back to when I had a paper that I wrote that was septoplasty in patients with suspected migraines. I submitted it for publication. This was, I don't know, 15 years ago, and it wasn't accepted. And you just start wondering, like, man, if people don't really get it, then they don't really get it. And I've approached some neurologists, of course, and those who have practices focusing on migraines, and I've wanted to work with them because I know that medications and the other things that they do don't help everybody. Um, and I said, I would love to see those people, the people that you don't help. Why don't you send them to me and let's see if I can help them? And boy, I get responses like, well, we don't, that's kind of controversial. We don't believe we see a lot of that. And of course, I'm thinking, well, if you're not an ENT, you won't see a lot of it because you don't look at the nose.
Right.
Um, uh, yeah, so there's resistance in that regard. I don't see a neurological journal wanting to publish things like that, which then leads me to say I have thought about and will at some point start my own journal. I just have to start my own journal, write my own things, have it out there so it's available.
There's I haven't read it in a while, but the Journal of Experimental Medicine,
Oh,
which
ah,
publishes, things like what you're discussing.
okay,
And
great.
they're more open-minded, and there's not much dogma. It's just like, let's think it through.
Okay,
Let's think through the mechanisms of action, the
right.
physiology, the biochemistry, the structural components, and like, let's just get rid of the dogma.
I like
But
that.
yeah, and I'm sure you know this stat, but it takes 17 years from bench to bedside. And so when people say standard of care, like, who's standard? Like,
Right.
I mean, we rank, the highest we rank in any category in America is 11th, and the lowest is 37th. And that data is like 7 years old. So it's
Hmm.
gotten worse. But we spend more than
Wow.
any other country on healthcare.
Right.
And so, the surgeries that you do, did you learn those through fellowship or continuing ed, or did you learn them through residency?
I learned them through residency and my fellowship. And then, when you get out and you start practicing, you start with that as your basis, but then you refine your techniques as you go. And that's been the most gratifying thing, was to take something that I learned and refine it. I mean, we didn't during my residency, we just started using endoscopes, and endoscopes during surgery, endoscopic sinus surgery. So before that, I mean, it was hard to tell how doctors were doing septoplasty. Like, what are you doing? What's
Right.
going on in there? So you can use the endoscope now, which is very effective in helping to teach those procedures. But yeah, when I'm operating, I have two big screens in my office. I have my CT scan projected on the one, and that's my roadmap.
Right.
And then on the other, I'm using my endoscope and looking at the monitor as I'm doing certain procedures, and I'm not really looking at the patient. But septoplasty, I am. But for the endoscopic part, where I'm reducing turbinates and doing balloon sinuplasty, it's really incredible and fun. It really is, because it's all, like I said, very logical. It's like these are the four things causing the problems. Let's make this normal. What I'm doing, I like to say, is I'm doing a normalizing procedure. It is invasive, but I'm doing it in order to normalize someone's nose. It's not an abnormality or an abnormal procedure. I'm not putting an implant in. I'm not cutting your nerves to get rid of the headache. A lot of people, not a lot, but some people have, neurologists actually had speculated, oh, so you're cutting a nerve or something? I'm like, no, I'm not cutting any nerves. I'm just restoring the nose back to its normal configuration.
Yeah, I mean, outside of Dale Bredesen, and I had a other neurologist, Ken Charlin. Dr. Ken Charlin, he's in Missouri. He's functional medicine minded, and he's trained in mold. Which, by the way, so I
Hmm.
first started reading about mycotoxins in
Yes.
2009, and I have the dreaded genotype, and I work with a
Oh,
lot of people who have issues detoxifying mold. And obviously, you want to get rid of the exposure.
yes.
But there's an ENT, he may have retired, but his name is Don Dennis. He's in Atlanta.
Hmm.
And he's
Okay.
the only ENT in the country I know of who's doing this. But he like cultures the pathogens from the nose.
Hmm.
And he said about 95% of nasal infections or sinus infections are due to mycotoxins.
Really?
And he'll go in and scrape the sinuses. In a really powerful case
Wow.
study, I have this nutritionist colleague who was suicidal,
Mm.
and she was obviously eating healthy and exercising.
Yes.
She had had mold exposure, and it had colonized and gotten into her brain essentially, and those
Yes.
mycotoxins were just constantly being
Oh my
released. And
gosh.
now she's great.
Oh, that's
She had the
wonderful.
yeah. And
That's
so,
an example of a doctor who's focused on his thing that they like, and they become an expert in it. We just have to get this stuff out, though. That's
right.
very, very impactful. I mean, especially for her.
Yeah, absolutely. And he said, I'm trying to find residents and fellows who, because he was 70 something the last time I
Yes.
talked to him, who can follow in his footsteps or take over his
Oh,
practice. But
wow.
hardly anyone was interested.
Oh my gosh, that's a shame because all of that work that he done over career.
Yeah.
Wow, you want to leave that with somebody, and that's part of what I have to do too. I'll start a fellowship program to train ENT surgeons in the procedure that I do, how to read a CAT scan, how to pair it with a headache questionnaire, and come up with a surgical plan in order to help these people. So that I'll be working the rest of my days because I have a lot of work to do. But yeah, it's fun.
Well, yeah, that's awesome. I mean, that you're continuing to push the envelope and think things through.
Hmm.
Um, there's a syndrome called Dennis Robertson syndrome.
Mm.
And the ENT I just mentioned is Don Dennis, and the
Yes.
endocrinologist is David Robertson, who
Oh,
I'll meet with tomorrow.
okay.
But when mycotoxins colonize the paranasal sinuses, it lowers growth hormone by basically damaging the pituitary.
Mm.
And so I take low dose growth hormone, not an anti-aging dose, but just
Right.
enough. My levels were that of like a 90-year-old man.
Really?
And yeah, and so people ask
Wow.
me the gym, like, what are you doing different? I'm like, I'm doing the exact same workouts I was doing 3 years ago. The
That's
difference
so
is now I
good.
get results.
Right.
But it's public. If you go to PubMed and type in Dennis Robertson syndrome,
Okay.
it's named after them, but you know, it wasn't widely accepted and not many people know about it. I just
Yeah.
happened to live in Atlanta, back
Wow.
like 5 years ago. And so I met with those guys.
Yes.
And we talked about mold because it takes a village, right? Like not everyone can do
Yes.
everything.
That's right.
And so, but I mean, I think when this whole evidence-based medicine thing, I think it may have originally had good intentions, but now it's meant to kind of bring critical thinking to a screeching halt.
Mm.
Because every time I hear someone say, well, there are no studies. Well, there's no double-blind placebo-controlled trials showing that parachutes work either. That doesn't mean they
Right.
don't work,
That's right.
you
I heard
know?
somebody else use that same analogy just recently this week. Yeah, and it's true though.
Yeah. I mean, and when you go around saying that, first of all, you sound like you're in a cult. Like, that if that's
Uh-huh.
your response to everything.
Mm-hmm.
But if you just stop and think through the mechanisms, like, is this plausible? And,
Right.
is it safe? Like, if it's dangerous,
Mm-hmm.
then I understand, yeah, there needs to be
Yes.
studies.
That's right.
But if it's safe and the worst thing that can happen is it doesn't work, then why
Right.
not try it?
Right. That's my case exactly. I've cured thousands, about 5,000 people. That's enough evidence that what
Yeah.
I'm doing is working. These are people who had migraines for 20, 30 years, you know?
Right.
And they tried everything and they've been diagnosed by neurologists all over the country. I don't diagnose migraines. There's a criteria that must be met. Neurologists know those criteria. My patients have seen several neurologists for years. So it's not like they don't have migraine. They do. And they have my procedure, and 90% of them don't have it anymore. Yeah.
Yeah, you would think. I mean, if I were the neurologist and I saw my patient get better, I'd be like, oh, I need to learn about this.
Right.
Not that
Right.
I'm going to do the procedure, but
Right.
I can send people.
Let's work
Um,
together. And then they get the accolades for saying, man, Dr. So and so helps cure folks, because he
yeah,
has a relationship with Dr. Smith. And I have one neurology friend that does send me patients. He knows what I do, but he doesn't know to the extent. I've kind of been easing up on him. Like he sends me those people that he looks at the MRI, the brain scan, and he can see the septum in his bent. He'll send it to me. That's the most common abnormality that I treat. But there are others as well. But I joke with him a lot. I'll call him and say, "Hey, let's go in and win us a Nobel Prize. Just work with me, and you're getting ready to retire. Let's work together, win a Nobel. We can both get one, and call it a day." And he'll
yeah,
say, "Oh," he'll chuckle as I'm not serious. I'm serious though.
yeah,
I'm like, it would be great to have a neurologist to work with me and for us to really, because they have the patients. I've got to market to the patients, but they have the patients. Let's just do a study. Send me 20 folks. Let's see the incidence of finding these abnormalities. I fix them, and what's the result? And let's publish some papers, and let's go on and just get this done.
I can guarantee if your procedure was connected to a pharmaceutical, then
Oh,
it would be published and it would be,
yeah.
lauded everywhere the world
That's
around.
true. That's true because even I can go on social media and there's some of these migraine groups, And sadly, I read through some of the comments and I say, man, I can help all these hundreds of people that are talking about taking stand back and a Coke and caffeine helps me and this helps me. And then I make a comment and I get blocked,
Yeah.
but I'm actually I can help all of the people on all of those migraine sites that are looking for help, and they just aren't open to it, and it's just it hurts, it just
Yeah,
does, because you want to help everybody.
absolutely. And I think a lot of these three-letter alphabet agencies, like the CDC, for a long time, they said, we don't receive any funding from Big Pharma. Well, now
Hmm.
on their website, they say 46% of their annual operating budget comes from pharmaceutical funding.
Right.
50% of the FDA's budget comes from there. So, I mean,
Wow. Yeah,
yeah, and
so how do you break into that? How do I
right,
go in and say, you won't need any more medicines if you go have my procedure? They don't want to hear that. And so
right.
when I see, and I know that some of these sites are sponsored by Botox, which they're using for migraines now, then that, or all these different migraine medications, how are you going to break into that? How are you going to break
Right.
into that? Yeah.
I'd love to get your thoughts on Botox because, you know, Kendall Stewart taught me a lot about neuroimmune syndromes. A lot of times,
Hmm.
what we call autoimmune is neuroimmune, since they share a
Hmm.
lot of receptors.
Hmm.
But I feel like there's going to be a lot of people with neuroimmune syndromes. Well, they already are, but there's probably
Hmm.
going to be more from people getting Botox, even in their 20s. I mean,
Hmm.
I understand, like, like migraines, for example.
Hmm.
But then again, why not come see you
Right.
and, clear the structural
Right.
component.
Right.
But what do you think about Botox?
Well, when we look at who's doing it, mainly neurologists. Neurologists don't do surgery. All they have at their disposal are medications and things like Botox. And someone, I guess, found that you can use it in patients and it helps, but it's treating the distal end of the nerve. And if it helps for those people that it does help temporarily, uh, I don't get migraines, but I've heard the stories. And so anything that would help eliminate a migraine for a little while, those people are going to want to have. So, I mean, in that regard, I think it has a purpose. However, it's a repetitive procedure that has to be done. And as far as what it does systemically, I don't really understand. But uh, again, my big belief is you can use that, and maybe it's good for people. And even medications are good. Let's just talk about medications are good though for those people. If they work, they're good for those patients who cannot have surgery for whatever. They're not healthy enough. They can't undergo general anesthesia. They can't have surgery. They have a bleeding disorder or something that can't be corrected by plasma or some factor that they can get. And maybe for those people, or those people who just don't want surgery, for those people, then the medications would be indicated, as long as it helps. But for the majority of folks that are healthy and looking for a cure, then that's when I would come into play.
What role does stress play in migraines?
Let's just talk about inflammation in general. Stress, of course, is going to release the cortisol and the
Catecholamines.
catecholamines and everything, and can certainly cause the nose to swell. Anything that causes the nose to swell, autoimmune disorders, inflammatory conditions, inflammatory diets, which is why when you get on an anti-inflammatory diet, for some of my patients, they say it improves their migraines. It helps get rid of them. Well, really, it's helping to control them. I know that if you have migraines, you have the abnormalities that I look for. I used to say, send me the scan to see if you're a candidate. And I know now that, well, 100% of the people have the abnormalities, you're a candidate. I'm really getting the scan to see what your abnormalities are, what the anatomy is, so I can formulate the plan, because the plans are all different. The surgical plan is different. It's customized based on what I see. Um, but yeah, if you can control or reduce the inflammation by any means, you will, in some cases, help to reduce the number of migraines or the severity of the migraines. And yeah, that's a good thing too, because not everybody knows about me, but if you can control it because you heard that works, then yes. But you still have the abnormalities, and they could still creep up every now and then and have a breakthrough migraine.
And your procedures, are they done in a hospital with an anesthesiologist?
Yes, they're done at a hospital with an anesthesiologist. However, I also do them in my office with in-office anesthesia. It's still general anesthesia done in the office. We screen the patients to make sure they're healthy to be done in the office. If not, if they have any conditions that I'm concerned about, I will take them to the hospital. So we scrutinize them very well because we don't want any issues. But yeah, it's done in the office. It takes about an hour. Like I said, it's covered by insurance. I use the same codes that a nasal sinus surgeon would use. However, the procedure, I must admit, is different than other ENT surgeons in that I'm doing it to eliminate migraines and chronic headaches instead of decreasing the number of sinus infections or helping you to breathe better. One of the benefits, though, of my procedure is that you will breathe better. You will have fewer sinus infections, and all those other conditions we mentioned earlier may improve, but certainly then the migraines and chronic headaches are gone. It's not a painful procedure either. Most of my patients will take Tylenol by the third day, and for those out of town patients, I have patients just this week from California, Nevada, and another out of town city. And by the third day, I tell them, I encourage them, I want you to get out of your Airbnb, drive down to Galveston, go to the mall, go walk here, take some walks in the morning, go to the medical center, the largest medical center in the world, go see that in Houston, and do some things. And surprisingly enough, I'll call them sometimes even the night of surgery. I'll call and check on them. And they're like, "Hey, Dr. Smith," and I'm like, "Didn't you have surgery today?" It's like, "Yeah, but I feel okay."
Yeah,
So yeah, it's not a bad thing.
absolutely. There's something called SPM, specific pro-resolving mediators. They're
Mhm.
derivatives of omega-3 fatty acids, but
Okay.
they turn off the inflammatory response. So I had a naturopath on who's in Arizona, and he does regenerative injections like in the
Okay.
facet joints.
Yes.
And he trained at the Riordan Clinic, Neil Riordan, I think it's called. But he said he allows people to be inflamed because obviously you want the inflammatory response for day one and day two. Day
Right.
three, he'll give them the SPMs, and then they start taking those, and then the inflammatory response goes down.
Wow, that's incredible. See, this stuff is just exciting for me to hear. You get to hear all this exciting stuff because you're doing your podcast and talking to these different people. And man, that's incredible. People are doing some fantastic work,
Yeah,
and it'd be great to just compile all this stuff somewhere. And I think the experimental, uh, uh, what did you call it?
Journal of
The
Experimental
journal of
Medicine.
experimental medicines is one way. Yeah, to just kind of store all this wonderful. You got me thinking
Yeah,
about a podcast to have all these people on talking about these different wonderful things they do.
absolutely. There needs to be more collaboration. In your practice, do you still do things like tubes, T tubes in the ear?
I don't. That has been one thing. I have a otologist that I send that stuff to if I run into ear problems that just aren't corrected with my uh, procedure that it improves the nasal airway breathing. Then I send those out to a neuro-otologist. Yeah. Yeah. So I
Gotcha.
have I have a lot of people I know. I've been in Houston a long time, and it's good that you start developing relationships with people you know that they are experts in their field too. And so I have them in my back pocket and use them when I need to.
That's awesome. Have you met the guys from the Vet Life? Have you seen that
No,
show on TV?
no, I have not.
Yes, so it's three guys who went to Tuskegee School of Veterinary Medicine together.
Okay. Uh-huh.
And then they open, I think it's called Sci-Fair, like
Okay.
CY and then FAIR.
Yes.
And I think they have multiple locations, but they have a reality show on the Learning Channel.
Oh, I'll check
Um,
it out.
yeah, and they're in Houston, and they're doing cool stuff.
Okay.
And they're all African Americans, so
Uh-huh.
there's not a lot of African American veterinarians.
Right.
So that's pretty cool. So maybe you could
Yeah, I'll
reach
check
out.
that out. I will. Thank you so much.
Yeah, and they do house calls. They go to farms and everything, and
Wow.
yeah,
That's
so
really
it's pretty
neat.
cool to
Okay.
see. And they do stuff with like laser veterinary medicine. I found is a lot more open to quote unquote
Mm-hmm.
experimental things. So like
Uh-huh.
class four lasers, which are fantastic. Instead of jumping to orthopedic surgery, let's try the laser. Like worst case
Yes.
scenario doesn't work.
Work
Um,
right.
or some dry needling, something,
There we
some
go.
manual therapy.
Right.
But yeah, I heard that Houston is now the third largest city in the United States. Is that true?
It I know it was encroaching on what Philadelphia to take over that spot, and Yeah, I think we're there. Houston, I really like Houston. When I travel, I tell people all the time that Uber drivers, people like in other places like New York or something, I say, if you ever get an economic downturn and you don't know what's going to happen, you lose your job, whatever. I said, here's what I recommend: sell everything, keep what you want, get to Houston, and you should be able to get at least 2 jobs in the first week, if not the second week that you're in Houston. In
Yeah,
Houston, it's just in Texas in general. When there's an economic downturn in the country, might get a slowdown, but we don't really get hit hard. And I tell
right,
people you can live in Houston and we can visit other places. And because it's
right,
centrally located, you can fly to the East Coast, West Coast, Mexico, Hawaii, Europe, South America, Canada, all from
right.
Houston. It's a great hub. People from all over. It's a very diverse city, very accepting city for the most part. Um, and I love it. I love the medical center, knowing that it's the largest in the world. It has what, 2 medical schools, 3 nursing schools, 11 or so hospitals. It's like its own city within Houston.
Medical center, is that in the Anderson?
The Texas Medical Center, Indiana's, is one of those hospitals it's the largest in the medical center by far. It's grown since I was a resident back in the day. But it's just a fantastic place where you just know it's just loaded with lots of information, lots of good stuff going on. I mean, I did a rotation with Denton Cooley, the famous heart surgeon, for 2 weeks. That's where I learned how to suture. But man, I'm in there as a student with my hand in a guy's chest. I'll never forget it. I'm holding this guy's heart, and Cooley just walks in, changes his gloves nice and slowly, is very slow and meticulous and intentional with his movements, said very little. The surgical techs knew the procedure so well, he never had to ask for an instrument. It was just the way he positioned his hands. They just knew what came next. And so I'm holding this guy's heart. He's standing right in front of me, and I'm holding the heart while he's doing a mitral valve replacement. And I'm saying to myself, I should just move. So he says, "Hold still, son." And I'd have something to tell my grandkids. But I didn't. I held it steady. He did his surgery, but it was really nice. That was a great experience. So stuff like that's in that
Excellent.
medical center. Yeah.
Yeah. And where did you go to undergrad? I know you played football.
Yeah, I went to Michigan. I was fortunate enough. I came out of Dallas Carter High School. That's the team in the Friday Night Lights movie that beats the main team, Odessa Permian. So I was a quarterback and defensive back at Dallas Carter. Got a scholarship to play football at the University of Michigan. Chose Michigan because I knew I wanted to be a doctor. They were top 10 pre-med, top 10 football. I was like, okay, this is an easy choice. So I chose to go there over Oklahoma and Notre Dame and University of Houston. And then I came back after that and went to medical school there and at the UT here in Houston, came back home to Texas and been here ever since. And it was the greatest decision. I love, we won the national championship this year. I got to go to the game. It happened to be in Houston. It was just a great scenario for them to end up playing here, winning the game, and a very proud moment for me.
Yeah, Michigan. I mean, I've heard great things about, the academics.
Yes,
Even though it's a pretty large university,
it is.
which, normally you don't associate with being good at academics, but that's not the case with
Yep.
Michigan.
No, it is not. They are top 10 in most of the degrees that they offer and the programs that are there. It's just a great school. It really is. I enjoyed it there. And playing football, it was tough. I'll be honest. It was very tough to try balance the pre-med with the football because we practice and go to training table, get out at 7 o'clock, and it was like that's when you had your time to study, and you're just so tired, from practicing. But it becomes a routine, and it actually required you to be very disciplined because the only time you could study was after 7 o'clock. I mean, it was very structured.
Yeah.
But at 1:30, I'm headed down there to get my ankles taped, ready for practice. We're going to be in our meetings. And but the practices, I can say, they follow the NCAA rules. We can only practice a finite amount of time. And I mean, practice went like clockwork, and then it was over in an hour and a half. It wasn't 3 hours, you know, and training table, then studying, and then they do the same thing the next day. you know.
Did you ever run into an issue where they were encouraging you to not take difficult classes?
No, no, they didn't play that there. The reason I chose Michigan really was because there were a lot of people like me. We had pre-dental guys, pre-law. Uh, we had this 6-year undergraduate MD program that I'll never forget. Mark DeSantis, he was a lineman. He was in that program. So he's playing football, doing the undergrad and medical school. In 6 years, he got his degree.
Wow. Are there
It's
many of those programs left where you can
I
cut
don't
out?
know. I don't know, but I thought it was just remarkable that he was able to do that because it was just it was so tough for me just to be undergrad, much
Yeah,
less try to do medical school. Yeah, but so there were a lot of guys like that,
yeah,
and today I have friends when we met down here in Houston, there were lawyers and dentists and doctors and and so business people. So it's just like a great institution. I loved it. I made a good choice there.
yeah. Similar situation at Wake Forest. I didn't play
Yes.
football, but I tutored some of the athletes, and
Yes.
I remember he was the starting middle linebacker, and he was also a double major.
Mm.
And I'm thinking, I'm having enough time, with a double minor in chemistry and biology
Right.
and my major, and you're playing football. I mean, you couldn't be a dumb athlete. I remember one of the soccer players who's now an MD in
Hmm.
Winston-Salem. He got a perfect score on the SAT, like
Oh my
perfect score,
gosh.
not one question wrong.
Oh my
Um,
goodness. That's
and
incredible.
so, yeah, and it's similar Duke and places like that.
Yeah.
But yeah, it's tough. I mean, I don't know if I would have been able to do what you did in terms of
Yeah.
practicing all day, weight training, rehab,
Right.
film study, then
Exactly.
studying organic chemistry,
Oh my
etc.
gosh. Yeah, organic chemistry. Mm.
Yeah. So
Yeah.
where do you see your practice heading in the future?
Well, that's a very good question. I see myself taking away from the surgical side where I'm actually doing the surgery and training other surgeons. I see having a fellowship. I see traveling and lecturing on what I do worldwide. I see training ENTs in different university settings like Johns Hopkins or a Mayo Clinic or a Stanford or Michigan,
Mhm.
because that will be the best way for me to educate those ENTs so that we as a whole can help more people. I'm only one
Right.
person now with 40 million people in the United States. We need more people doing what I do. And even that won't be enough. Um, but I see that happening. I see having a practice focused mainly on this chronic migraine and headache path. But I had an interesting call with one of my professors at UT who developed the mobile stroke unit that they use now here, I know, and probably across the country. And it occurred to me that there are a group of people that go in with stroke-like symptoms that have hemiplegic migraine, but they get worked up as a stroke patient. And they get a brain scan. The brain scan is normal. And for a stroke, I need to see a clot or a bleed. It's one of the two.
Right.
But those people that come in with those symptoms have to be given a diagnosis. And I do believe oftentimes they're probably in the category of TIA and mini stroke. So I called him. I said, it just occurred to me that there are probably a lot of people that get the diagnosis of TIA and mini stroke that need to get a sinus scan to see if they have the abnormalities that I talk about. They may have a hemiplegic migraine. And there's a big difference between a hemiplegic migraine that I can get rid of and you saying in your health history that you had a mini stroke. There's a big
Right.
difference there. And so he said, that might be the case. So I said, well, send me some. Let's see. Let's do a study. That's just how
Yeah.
my mind works. I'm thinking,
Right.
and there's got to be some people where that's the case, but we won't know until we do the study. So if you had a
Right.
TIA or a mini stroke and you're curious to find out if it might be a hemiplegic migraine, send me a sinus scan. Let's see. So
Absolutely.
that's the kind of stuff that I'll be doing.
Well, that's awesome that you're still enthusiastic about what you're doing
Oh,
and,
yeah.
not just doing the same old thing. You're constantly evolving. What's something you know today that you wish you would have known 10 to 12 years ago?
Well, I can say I wish I knew 10 to 12 years ago that this was actually the root cause, I would have pushed even harder earlier and had more time, to really, I would have been further down the road with it. But that's okay. Some things you just don't learn until you have experience. And I'm
Right.
accepting of that. And it takes experience to learn some things. And so,
Right.
yeah, I'm comfortable with that. Yeah, I'm just happy, very fortunate that I discovered it.
Where can people find you if they want to come and see you or send you a scan?
Yes, you can go to kevinsmithmd.com is the website. My Facebook page, Smith Center Otolaryngology, has dozens and dozens of video testimonials. That's the best way to go and kind of immerse yourself into all these videos and really get a sense of how we take care of people at my office. And then my office number is 713-795-0600. We'd love to hear from you. We'd love to help you, help a loved one, help a colleague, help a friend, and a lot of times we get referrals just based on that. They say, oh my God, my friend's dad has migraines, or my friend's mother, has migraines, or whatever.
Right.
Just give us a call and we will walk you through the process. Or if you're in Houston and Texas, just make an appointment and come see us. I actually have a scanner in the office. You get a scan on the spot. You'll review the scan with me. You get the exam. We talk about the surgical plan. You pick your date for your procedure. We send it off to insurance to get it authorized, and you're in the system and we're ready to go. It's really efficient.
That's awesome. Well, thanks so much for the work that you're doing. Hopefully, we can have you back on in the future for some updates.
Well, thank you very much for having me. And I want to congratulate you on this fantastic podcast and the work that you
Thank
do.
you.
You're doing a lot of great work by having me on and having all these other people on your podcast. I mean, it's just a wealth of information. So congratulations to you
Oh,
and much
thank you.
success in the future.
Absolutely. Have a great day, Dr. Smith.
Well, thank you. You have a great day too.